We're good now.
Okay.
Okay, look, you're still there too. All right, go ahead, if you would, and tell us a little bit about yourself, including your name.
Okay. So my name is Michelle Wands. I am a nurse practitioner, specifically an adult geriatric nurse practitioner. I have been a nurse for 25 years. After 17 years, I decided to go back and get my master's.
Mhm.
And I obviously love children, love babies, but I do not want anything to do with taking care of them. I have always worked with adults and older people, so I went the adult geriatric NP route. So,
I didn't realize you were a nurse for 25 years. I thought you were married longer than you were a nurse.
yep,
But
isn't that crazy?
it is crazy. 25
Uh-huh.
years too is crazy.
25 years, done a whole lot of different things. I've been inpatient, outpatient, surgery, trauma, ICU, you name it.
Dang, girl. I didn't realize you
Oncology.
did all that. Dang. Um, Now you're specially, are you still with Dr. Kirby at Lake Norman
Yes,
Arthritis?
yes. So I work in rheumatology and it found me. I knew there were certain things that I did not want to do. Just that was one of the nice things when you've been a nurse for so long and you've been around and done so many different things, you really learn what you don't want to do. I never thought about rheumatology at all. And once I graduated, took a couple months off to just decompress and sleep. And then started interviewing. I interviewed for a couple things, turned them down. It just wasn't a good fit. And then he found me and said, you've done orthopedics, you've done primary care, you've done, all these things. And he said, I think that you would be a really good fit. So anyway, we met via Zoom like this, or a couple of times, 2 or 3 times, and then I went and spent the day with him. And it's a little scary because when we're in school, we're basically taught everything we need to do until you would refer to rheumatology. Right? So
Yeah.
the labs are very specific. The conditions are very specific, and these patients are puzzles and they're mysteries, and we kind of get like, oh, I don't know what's wrong with you. It must be rheumatology, right? Symptoms.
Right.
So I really like the challenge of it. I really like the patient relationship that I have. It's a long-term relationship with people. I like that it's very humbling. People come in and can barely walk, but at the same time, it's very rewarding because you can see that you are making them feel better. You're making a difference, and they really value you. And I feel like because you're helping them, that they become also, for the most part, there's always some compliant too. So your compliance level, I think, is higher than some of the other fields because they feel better. So they're going to be compliant, right? So you have things like hypertension where you can't necessarily feel, most people don't feel they have hypertension, right? The silent killers and stuff. And so they're not necessarily compliant. But if somebody feels better, they're going to be more compliant.
Yeah.
Yeah.
That totally makes sense. I can see that. They can, not walk very well, and then, they see you and then are able to walk without pain.
Right.
Yeah, that makes a big difference.
It makes a big difference.
Makes
Yeah.
a big difference.
But I love it. I've been there 4.5 years already.
Dang, it's been that long already?
Yeah. Yeah. And I could see myself here, really forever. I think I just kind of landed in a really good spot. And Dr. Kirby and I have a really good working relationship. And so I think that it just works really well. And it's hard because obviously wanted something that was part-time. And I think that's hard for doctors to find too, because most people do need benefits and all those things. And with Charlie working, and he holds all of that for the family. I don't need that. I still need to have enough time to be a mom too. So it works really well.
Right. Yeah. Tessa and Tristan still need you.
They do.
Okay. So, do you see a APRN influence in today's healthcare system? If so, how? Or if not, why?
Okay. It's certainly not no. I do. I there's a lot of influence by us. So I don't know how it is there. I'm sure it's probably a national problem, but we have these shortages of physicians, and people aren't going in to medicine, or certainly not going in to be doctors, which is understandable, from the standpoint of not only the cost of it, how many years it takes, but then for, a lot of time they're kind of pigeonholed into what they focused in, and if they get out and if they don't like it, we're here PAs or NPs, we can learn on the job, we can change directions, and we can change what field that we're in. So it's there. I have a lot of patients that have come in and, my doctor, it's not that they're retiring. I think they're very stressed out from their patient load. I think they're very stressed from the big entities saying you only get 10 minutes a patient or 15 minutes a patient, and it's not enough time. And so most of them are even completely changing directions. I mean, I have physicians I know that have stopped and gone into real estate. I mean, they are completely getting. So having more, APRNs come in to the workforce is needed to help mitigate that, but we still need the physicians. We still need the expertise. Because we can do a whole lot of things, but when they're in their residencies for so many years and things like that, we don't have that.
Right.
So we have to be taught by somebody and have that expertise there. So that's certainly one way. So another way that you might hear it from time and time again too is that patients, I think most of the time patients really like to see kind of a physician when they're a new patient. And for the most part, a lot of times we kind of get handed off to an NP, right? And at first they're kind of like, I don't really like that. But then they get to know you. And I think that time again, you'll hear people, it comes out of their mouth, I will see an NP any day over a physician, because we listen, we take time, we're more focused on the whole patient. So I think that's one thing that would influence healthcare, certainly in a good way, for sure. So the other thing is, because of that, because we can spend time, because we can listen, then the outcomes are better. The patient satisfaction is better. I think it's more, APRNs are more focused on preventative medicine. I think we're more open to complementary medicine. People are getting very good at self-educating themselves. And they're coming in with, and it's most of the time it's correct information and it's valid concerns, right? And it's a lot of them too. Like, there's so much more talk now about just being proactive and what can, they want to say, what can I do? I know I have to be on these things because I have this disease, but what can help, and so there are more supplements and diet and exercise, just things like drinking water. Well, I mean, we are almost 80% water. We need water. And, so that just really trying to look at them holistically. Just even I had a patient yesterday that, her disease process is worsened, obviously, by stress. I mean, that's going to exacerbate a lot of things, right? And so we talked a lot about, I said, okay, let's just talk about, when you say that you have so much stress, what is the stress? And it was to talk about, like, can we make an effort to decrease it? Or is this things like, it's financial strain, it's, things like that, or your husband has cancer. Well, we can't decrease that stress. So, but all those things, they all influence healthcare.
And it's actually funny that you say that, a lot of people they'll say like nurse practitioners any day. So Jake's dad actually went and saw a medical doctor, physician, because he's having symptoms, and they're like, oh, there's nothing, what does Maj feel? Well, then he followed up with his nurse practitioner, and his nurse practitioner is actually the one who diagnosed him with the prostate cancer that he had.
Ah, yeah,
Mm-hmm. Yeah,
yeah,
because I'm like, he's like, I'll go see her, anytime, because she's like you said, she listened, and looked at
right.
everything, and did the test, and then was the one who found his cancer, and then she was actually the one who, I forget where he had a hole somewhere in his heart. I forget where, for specific, but she's the one who also found that and sent him to have surgery.
Yeah.
So I
And it's
totally
like
get
that.
it.
Yeah. It's like listening is taking time. It's being able to ask those real pertinent questions that you're supposed to
Mm-hmm.
ask so that way you can get to the right diagnosis in a timely
Mm-hmm.
manner,
Yeah.
and the other thing it's too, it's one thing where of course, there's a lot of focus of um, APRNs and access to care, right?
Yeah. Yeah.
So there's a lot of that, but I feel that really used to be more of a focus, I think, for underserved and rural areas. But
Mm-hmm.
now it's becoming more of a problem even in cities and suburbia because you have all of these physicians that are retiring or just
Yeah.
quitting.
Mm-hmm.
So, I mean, I had
Makes sense.
someone in my office this past week. She came in to me. She had an acute ankle injury. This is not a rheumatology problem. You know,
Right.
to me, she needs to go to her primary, but she couldn't get in for a week. Now, of course, she could have gone to urgent care. Yeah, but
Uh-huh.
I told her I might just come on in. So, of course, send her for an x-ray and I'm sending her to ortho and she just has a really bad
Yeah.
sprain. But, it's almost becoming an issue with not, it's more like within the city, I feel it's more timely access to care where we're
That makes
helping.
sense. Yeah.
With rural and stuff, it's just access, period. You know,
Yeah.
yeah.
Yeah, that makes sense. Yeah, instead of waiting like 3 weeks to get in for like a sinus problem, be seen more quickly than that. That makes sense. Yeah.
Yeah.
Um, so going off of that too, then what are some of the barriers that APRNs face?
So I think this comes more from maybe not necessarily the states. I mean, you can
Mm-hmm.
kind of argue the states, but
Mm-hmm.
more the physicians don't really know how to use us the right
Okay.
way.
Mm-hmm.
I think that's probably the barrier. I think, and I feel like the situation that I'm in, I have a lot of autonomy.
Mm-hmm.
We just make sure, he's an independent practice.
Mm-hmm.
It's him and it's me. And he had a nurse practitioner years ago. And then when he was independent, it was just him. And then
Mm-hmm.
he's realized I need to bring somebody back in.
Yeah.
So, it's just the two of us. And he's like, look, as long as one of the two of us are here,
Mm-hmm.
it's then most of the time he and I are there one at most 2 days a week at the same time. Other than
Mm-hmm.
that, we pretty much split the schedule. So we're busy, but we're not loaded, right? To where we
Right.
can't. And so it's nice because since we're independent, we get those 30-minute patient blocks. We get an hour
Mm-hmm.
of patients because he can set whatever he wants. We're not
Right.
controlling the big entities.
Mm-hmm.
Um, so I have talked to other people just going out with dinners and networking and things like that.
Mm-hmm.
So I've talked to other NPs within the same field,
Mm-hmm.
and they work with doctors that they can hardly do anything, and they don't
Mm-hmm.
have any autonomy
Mm-hmm.
and don't think the doctors really understand how much that we can do, you
Yeah.
know.
Yeah.
Uh, And I don't know how to fix that. I don't know if that's an individual problem, for the
Mm-hmm.
physician that maybe they just have a lack of confidence. Maybe
Mm-hmm.
they had a bad experience with somebody and they got
Yeah.
burned, misdiagnosed, whatever. And so,
Mm-hmm.
but I do think that is part of the problem.
Yeah.
It's that people just don't really know the best way to use us.
Yeah. Yeah. And I think that's probably like you're right. Like, I don't know if it's state or what, but it seems like there's a lot of providers who have that problem. So, it could be individual, but it'd be harder to just, go individually and educate them instead of just doing, like a whole big thing on it and everything.
Right.
So, yeah, I get what you come from. Like, that is very hard to, you know, figure out how to fix because it's, different everywhere, but yet similar everywhere, if that makes sense.
Mhm. Mm-hmm.
Yeah, because actually when I worked at primary care, it was the same. So they had 15-minute intervals for patients, and then they hit like a certain mark or whatever for how many patients they saw that month. They got like a bonus or something. So
Yeah.
it's just like add more patients in, add more patients in. It's like you don't even really have time to say hi or anything, and it's just like okay, bye.
Right.
So yeah, that's crazy. I'm like, you just got in there, now you're coming out already? Like,
Oh, I
okay.
know. Well, and I talked to, we have, because you've been to our office before, so we have the
Yeah,
infusion center too.
yeah.
And so I've talked to some of the other MPs with some of the rheumatologists in the area, and they say
Mhm.
that, oh, do you run the infusion center too? And I said,
Mhm.
yes,
Mhm.
So obviously we have new starts coming in, there's always a risk of any type of reaction, anaphylactic reaction,
Yeah.
just, anything.
Yeah.
And things do happen. I mean, we had someone went in new onset AFib 2 weeks ago.
Wow.
Yeah.
Dang.
I mean, so just anything can happen.
Yeah.
So it's, again, having all the experience and stuff that we've had for so many years, then you just know
Mhm.
what to do. But these particular MPs, they're like, well, we were meeting with our physician because we really want to run the infusion center. Like, we can do that,
Yeah.
and
Yeah.
they can. They said, for any particular medication changes or anything, they have to run that by their
Wow.
physician. Now, based on the North Carolina state, so this kind of
Mhm.
goes into this last question
Mhm.
about like, the changes, what like
Mhm.
changes would I like to be
Yeah.
seeing,
Yeah.
PRNs? I, it's so different per state as far as our practice ability,
Mhm. Like a scope.
the scope, right? So
Okay.
like North Carolina, right, we have we have to have that collaborative practice agreement. We have to have a supervising physician,
Mhm.
right? So
Mhm.
Dr. Kirk is my supervising physician.
Mhm.
However, he is there for me based on that practice
Mhm.
ability that and I don't mind having a supervising physician. I like it. I want to have someone in my pocket that I can call because
Yeah.
he's been doing this for 35, 36 years. He
Yeah.
taught at medical school and taught rheumatology. I mean, he loves to teach. I want
Yeah.
somebody that's seen something that's a weird presentation, or I
Mhm.
have a question about some kind of rash I've never seen before, but it's related
Right.
to some autoimmune something or other.
Yeah.
Um, so I like that. Does
Mhm.
it is it full practice authority? No.
Mhm.
That would be that I don't have to have a supervising physician.
Right.
But I think that full practice authority is something that we certainly can do.
Mhm.
Uh, and I think there's a lot of nurse practitioners that's what they want to do. They want to open up their own practice. They want to,
Mhm.
and do that. Um,
Mhm.
and I don't see anything wrong with that at all.
Right. Mhm.
I think, and that's just my personal opinion,
Mhm.
because I would not just open up a practice after I've been working for a couple of years. Like, I would want to feel like I
Mhm.
have a really firm foundation of
Yeah.
what I'm doing,
Mhm.
right? Um,
Yeah.
from a safety standpoint for patients,
Mhm.
just necessarily thinking about liability, but for the patient.
Mhm.
Um, but with but in North Carolina, I could go open up my own practice as long as I
Mhm.
have a supervising physician. So I'm still able to do that. I am able to see new patients, which I
Mhm.
do.
Mhm.
I diagnose, I treat, I change treatments, I do labs, I interpret
Yeah.
labs, I do diagnostics, I interpret diagnostics, I refer. I can fill out disability paperwork. I can do all those things. And
Mhm.
I feel like the only difference between that and the full practice authority is that I just wouldn't even have a supervising physician
Okay.
to
Yeah.
do everything,
Mhm.
but I have to have a supervising physician.
Makes sense.
So, but then you have the states that are just totally restricted, right? And so the
Yeah.
restricted, exactly like some of these MPs that I've run into where
Mhm.
I am, where they can't they can't diagnose without talking to their physician. They can't prescribe a
Oh,
medicine without
wow.
talking to their physician. They can't, and so he's treating them as if it's a restricted state.
Gotcha.
North
And it's
Carolina's not.
not.
Yeah.
That's crazy.
So, and that's where it comes from, like that barrier. I just think that, that
Mhm.
physicians need to understand where we are and what the restrictions are, if there are, in your
Right.
state. But
Makes
I
sense.
think the restricted practice that happens in some states,
Mhm.
why did we go back to school? Why did we went back to have autonomy? We went back to be able to
Mhm.
diagnose. We went back and we have the education to do it. We've passed the
Yeah.
national certification. We have to do our continuing ed.
Mhm.
And I feel like that particular scope should completely go away. Should go
Yeah.
away. Um, so I mean, those were just like changes. It would be better
Yeah.
if the states could figure out something and be more consistent.
Mhm. Yeah. Yeah, that makes sense. Especially like you said, where if you're going back to school for all this, why do you want to be that much restrictive? You know what I mean? Like basically, like why did you go back?
Well, exactly. And that's what I looked at these girls and I said, oh my gosh, well, that was like basically, I felt one of the reasons I went back is because I felt like nursing uh, became, I felt like I was a task doer where
Yeah.
we used to, work in the ICUs and have so much autonomy where the doctors would come in and say, thank you for doing what you did and not waking me up at 3 o'clock in the morning
Oh
and signing
wow.
the orders off after you've already done it, because you've learned critical thinking, you've done all these
Mhm.
things. And
Yeah.
as time went on, like all that was being stripped away. And, then it's like you didn't even have standard order sets anymore. That pretty
Oh
much,
really?
yeah,
Dang.
like there was even in Charlotte, you couldn't,
Yeah.
you know, give a Tylenol without
Mhm.
calling the doctor, which of course you would need an order for that, but
You're
usually
right.
standard order sets, and those weren't even happening anymore. So it's like, um, I told Charlie, I said, I need to go back to school. It's the only way I'm going to get back to being able to use my brain
Yeah.
and practice the
Yeah.
way I practice. Yeah.
Yeah. Because it's kind of silly, like if you have a ton of order for pain, but I mean for like fever, but they're having like a headache or something. It's like you technically can't even give it to them for a headache, and you have to go ask. And then they're like, "Why are you asking me?" Like, of course you can give it to them, and you're like, "Well, it's technically not in the order, so you know." But like you said, yeah, it seems very task oriented. That's
Hmm.
fine.
Hmm.
Yeah. Yeah. Okay. Well, I thank you for the questions. I'm gonna stop the recording though. Yeah,
You're welcome.
let me stop recording.